Well, thank you everyone for coming. My name is Amanda Shrewsbury, and I'm a cancer genetic counselor at the UCLA Health Clinic over off of Arrow Vista Place. And I work with Dr. Bianca Russell, who's our geneticist in the clinic. Her and I are going to cover a lot of ground today, but mostly we're going to focus on the genetics of hereditary breast cancer. So I'm going to kick us off, and I'll start by talking about some of the sciencey aspects of it and the genetic mechanisms of breast cancer. Hopefully I don't bore you too much going back to biology 101 in high school, but I promise I'll make it short and sweet. And then I'll talk a little bit about the role of genetic counseling and what a cancer genetic counselor does. And then I'll pass it off to Dr. Russell, and she's going to cover some of the history of cancer genetic testing in the breast cancer realm, and talk about where we're going in the future with genetic testing. Okay, so before I kick us off, I just wanted to get a sense of the room. Who here has seen a genetic counselor? You can raise your hand. Okay, awesome. So the whole middle row, basically. Who here has had genetic testing? Maybe it wasn't with the, okay, lots of people. All righty. So I'm going to kick us off by talking about some of the genetics of cancer, like I talked about, and going back to biology 101 into high school. So on this photo here, we have sort of a macro to a micro level from left to right. On the left, we're starting with a cell, and on the right, we end up with the gene. So our cells are what make up our body. We have trillions of cells inside of our body, and they contain all sorts of structures, but one of the most important structures that they contain are our chromosomes. Our chromosomes are the X-looking structure in the middle of the slide that have sort of these dark bands. And our chromosomes are the home for all of our genetic information. So they house our DNA and our genes. If you think of our chromosomes like a book, you can think of the genes like a sentence in a book, and the DNA like the letters that make up a sentence. So as people, we have 46 chromosomes, or 23 pairs of chromosomes, and we get one copy of each chromosome from mom and one copy of each chromosome from dad. Similarly, we get one copy of each gene in our body from our mom and one copy of each gene in our body from our dad. So we have 2 copies of every gene in our body. And genes in our body have all sorts of functions, but the genes that we're going to be talking about today are related to cancer. And their job primarily is to stop the development of cancer, which they do in a variety of different ways. Okay, so when genes aren't working so well, when they're not carrying out their jobs properly, it's usually due to what we call a mutation or a genetic variant. They're sort of used synonymously, so if you hear them both that way, you can use either one. But a mutation is when we have a change in the normal sequence of our DNA. So in the letters that make up those sentences of the books, sort of like the instructions and recipes for like your favorite cake you're making, for example. Our DNA code is typically made up of these letters A, T, G, and C that you can see on the right hand of the screen. But just for example's sake, we're going to pretend like we have more letters than that. And at the bottom here, I'm showing an example of a normal DNA sentence. So this sentence says, the dog ran out. But here's an example of a DNA mutation or a variant. You can see in this example, there were 2 T's added in front of the D for dog, and that sort of changed the rest of the sentence. It shifted it. This is what a genetic variant or mutation looks like in our genetic code, and the impact of that can be a change on how the gene is functioning and carrying out its job, which can ultimately lead to the development of a certain condition like cancer. These are just a couple of other examples, purposely just to illustrate that there are other types of changes that we can have in sentences. So we can have letters that are substituted for one another. We can have letters that are deleted, letters that are swapped around. All sorts of things can happen. So when we're thinking about cancer and how cancer develops, we think about what's called sporadic cancer and hereditary cancer for the most part. And I'm going to focus on hereditary cancer for most of the talk, but I have to talk about how sporadic cancer happens first for us to understand that too. So on the left-hand part of the slide, we see 2 copies, and we're going to call this a gene that's related to cancer. So these are one copy from mom and one copy from dad. And the gray means that this gene is working well. It's doing its job well, and it's stopping the development of cancer. Over the course of time for this person, in one copy of their genes, you can see that it is changed to a red color. This indicates that they developed a mutation in that copy of their gene over the course of their life. That could have happened in a variety of ways. Age is the main risk factor for developing mutations and developing cancer, but there are other things that can happen too. We can be exposed to different levels of UV. There can be different levels of environmental exposures, or just by chance, we can develop mutations in the genes in our body, just as our cells grow and replicate over the course of our life. For this person over time, they developed a second mutation, or we can call it a HIT. This is the 2-hit hypothesis of the development of cancer. You might hear it referred to that sometimes when you're talking to different specialists. And at this point for this person, neither copy of their genes in their body were working for this particular gene related to cancer, and this allowed for tumor development in the body. So for somebody who has a hereditary risk for cancer or a predisposition to cancer, that person is born with one copy of the gene related to cancer already not working. So you can see on this slide here on the left-hand side, this person was born with one red copy of the gene. So they already had an increased risk to more quickly develop a second copy of the gene or a second hit or a mutation and cause that gene to not carry out its job properly anymore. And thus cancer and tumors can develop more quickly for somebody with a hereditary predisposition to cancer. Okay, so I want to break a couple other concepts down that can be confusing. One of them is the concept of germline or somatic. And sometimes in the cancer community, we hear this talked about as germline testing or somatic tumor testing when they do testing on tumors related to cancer. So for germline mutations, this is what we were talking about in the last slide when I was focused on hereditary cancer. So somebody with a hereditary form of cancer has a germline mutation in one of the genes in their body related to cancer, meaning that at the time they were conceived, at the time of birth, for their whole life, they've always had that mutation in their body. It's in all of the cells in their body, and thus it can be passed down to future generations. Somebody who develops a somatic mutation, which is more the case where I was talking about on the initial slide with sporadic cancer, they develop that mutation over the course of their life in their cells as they're growing and replicating and dividing. So that person only has a mutation in the cancer cells in their body that have developed the mutation. So when somebody has a somatic mutation, they cannot pass that mutation down to a future generation. So it's just a distinction that I want to make because a lot of people have heard about tumor testing for somatic mutations. And when we're in our clinic with Dr. Russell and I, we're more focused on hereditary mutations. So the inherited risk that somebody's had for their whole life related to cancer. Okay. So I've alluded to a couple times the fact that there are genes in the body that are responsible for stopping the development of cancer, and there are different types of those genes. So two of the primary ones that we think about are called tumor suppressor genes and proto-oncogenes. And you can think of these sort of like the brake and the gas pedal in a car. So a tumor suppressor gene acts like the brake in our car, in that when it's doing its job well, it's stopping cancer from developing. So it's pushing the brake and the gene is functioning well. A proto-oncogene is more like the gas pedal in our car. So it's not always turned on, it's not always doing its job, but it turns on at certain times when it needs to intervene and help our cells to stop from developing cancer. When we develop mutations in these genes, the gas pedal and the brake are no longer working. So you can think of the tumor suppressor genes as defective brakes, so they can no longer stop our car. And you can think of a proto-oncogene as becoming what we call an oncogene and having the gas pedal or an accelerator jammed, so the car cannot slow down, it just keeps going. So why am I telling you all of this sciencey stuff anyways, and how does it relate to you? Well, it relates to genetic counseling, so that's what I'll dive into a little bit more now. But in genetic counseling, we talk about a lot of these concepts related to inherited risks for cancer, and we can help you understand your risk for hereditary cancer. In genetic counseling, we can also discuss different genetic testing options, different management, surveillance, and screening options, and even provide just different emotional support and resources as you're processing your risk for cancer and thinking about how it may impact other family members in addition to yourself too. Okay, so let's dive into the cancer genetic counseling piece a little bit. So what is cancer genetic counseling anyways? A lot of you have actually seen a genetic counselor, so that's really helpful. You have some concept of what an appointment might look like. But genetic counseling is really both an informational or educational process, as well as a counseling and emotional process. We know that the risks for cancer don't come without emotional consequences or impacts to other family members, and we spend a significant portion of our time talking about those impacts as well. In terms of the educational process, we do a lot of what I just talked with you about. We explain concepts related to the mechanisms of cancer genetics and breaking down how cancer is inherited in families. We also really talk with people about their personal and family history and how your unique history may or may not be related to an inherited risk for cancer. Additionally, like I've mentioned, we'll talk about testing options, prevention and surveillance or management options, and talk with you about other resources that we can connect you to. In terms of the counseling aspect, we provide emotional support in decision-making. Genetic testing is something that's always an option, but genetic counseling is the first step in that. So when folks come to see us, they're never pressured into genetic testing. We understand that it's a very personal choice, and we want you to feel empowered and autonomous over that choice too, and making that decision for yourself and your family. We also will talk with families and patients about the impact of other family members in terms of the hereditary risk. We know that genetics is a family affair, so your genes are shared with your other family members, and you're probably concerned about them too if you have an inherited risk. So when we think about who would be a good candidate to come to our clinic, this pie chart helps us to understand it a little bit further. So the biggest part of the pie chart is the sporadic cancer part of the pie chart. That's what we talked about earlier on, when that person had 2 copies of the gene working but developed mutations over the course of their life. So sporadic cancer actually accounts for most of cases of cancer. It accounts for about 60 to 80% of all cases of cancer. And that just happens by chance. You might see it maybe in 1 or 2 related family members, typically people at older ages. And like I said, age is the biggest risk factor in general for developing cancer, but people can develop cancer sporadically for all sorts of reasons over the course of their life too. In our clinic, we work with people who have a hereditary risk for cancer, which is about 10 to 15% of all of the cases of cancer. And hereditary cancer is a grouping or a clustering of cancer in a family due to one of those inherited genetic changes that I was talking about. So we can see these changes passed down from generation to generation. And then the smaller portion of the pie chart in the middle is regarding familial cancer. This accounts for about 10 to 20% of cases, and that language can be a little bit confusing at first. But familial cancer really refers to cancer that can be due to both a combination of genetic factors as well as other shared environmental factors, like lifestyle or location of living, where you grew up. Things like that can play into familial cancer. This is really a burgeoning area of research and in our world too, and I expect that over the next 10 to 15 years, we'll know a lot more about familial cancer and how to better characterize the risks for people who fall into that category. Okay, so who should have genetic counseling more specifically. There's a lot of different risk factors or kind of red flags that make Dr. Russell and I and other clinicians think about when it would be good to send one of their patients to see us in cancer genetic counseling. So I'm going to throw a lot of bullets on this slide. It's not an exhaustive list by any means, but the main takeaway is, I think, to trust your gut. If you feel like something is off in your personal or your family history, a lot of people have cancer, or you were diagnosed with cancer at a really young age, just follow your gut. It's better to have a conversation with us where we can talk about these things than for you to not be seen at all. But for folks who have a personal history of breast cancer diagnosed at age 50 or younger, you're a particularly good candidate. People who have certain types of breast cancer, for example, triple negative breast cancer, multiple primary breast cancers, lobular breast cancer, especially if there's stomach cancer in the family, male breast cancer, which is particularly rare. Folks who have Ashkenazi Jewish ancestry, we know that there's an increased risk for several genetic conditions, but some of them are cancer related. Individuals who have more rare forms of cancer like ovarian cancer, metastatic or high risk prostate cancer, pancreatic cancer, or other colon or other cancers at an age like 50 or younger. Tumor genetic testing. So this is something I alluded to a little bit earlier. When we send somatic tumor genetic testing, looking for the sort of genetic composition or makeup of the tumor that's identified, sometimes there's a genetic mutation or change identified that makes us in the genetics world think that that person should be seen in a hereditary cancer clinic. And then lastly, bilateral cancer. So for example, if somebody has cancer in both of their breasts or in both of their organs, if there are two of them. Oh, down here too, I have a known genetic mutation or condition in your family. Definitely, if you know you have an inherited risk, please come see us. Okay, and then family history. A lot of it is similar to the previous slide. So if you have family members who are diagnosed with cancer at young ages, family members with some of those more rare forms of cancer like ovarian or pancreatic cancer, multiple cancer diagnoses in family members, like a lot of breast cancer in the family, a lot of prostate cancer, a lot of colon cancer. Those are good times to come see us in genetic counseling. And then there's a variety of other reasons why you might come see us too. People who had genetic testing 10, 15, 20 years ago are good candidates to talk with genetic counseling again, particularly in the breast cancer realm. A lot of people are familiar with the BRCA1 and BRCA2 genes. And 10, 15, and 20 years ago, the technology was not what it was in terms of genetic testing. So there may be updated testing options in terms of your cancer risk. And then folks who have certain types of findings on an exam like colon polyps or particular types of colon polyps. And then rare tumors or cancers like neuroendocrine tumors or pheochromocytomas. Okay, so genetic testing is always an option, like I said, but it can be sort of an elusive process. And I just want to demystify it a little bit. It's actually pretty straightforward and simple. So during a genetic counseling appointment, we would talk about your testing options. And we can do a genetic test that looks at the genes that are related to your particular personal or family history of cancer. The sample for the genetic test is usually just collected right in our clinic with a cheek swab. So it's super easy. It's even easier than the test for like the COVID testing, which was painful for a lot of us. But saliva and blood samples are also an option as well. And insurance typically covers the cost of testing, which I think can also be surprising to people. So especially if you fall really well within those categories that I listed previously, insurance will more likely than not cover your testing. In my experience, most of our patients don't pay anything for cancer genetic testing. The most that I've seen somebody pay just in general in my time working is about $250 for a genetic test. But a lot of the laboratories we work with also have financial assistance programs too. So even if there was an out-of-pocket cost, we can work to bring that down too. And then we usually send the sample off and you wait for 3 to 4 weeks. After that, we have a follow-up appointment with myself, and we talk about the results in depth and talk about other family testing options if that's something that we recommend at that time. Okay, so I'm going to hand it off to Dr. Russell now, and then we'll answer all of your questions in combo at the end.
Okay, that's a tough act to follow. Ooh, the sun's also
hot spot right there.
this way. A little bit. Okay, thanks, Amanda. That was great. Really excited to have Amanda here too in our community. This is a big deal to have a genetic counselor here. So thank you for coming and joining us and giving us that great intro. So Amanda alluded to some of the history that's been involved in breast cancer, genetic testing, and genetic testing in general. So I borrowed this from somebody, and then I still spent an hour on it, and it still looks a little crazy, but I think there's some really important points on here that are worth sort of mentioning. So genetics is a concept that we've understood for a long time, all the way back to the 20th century AD, where we actually found Jewish writings that talked about if 2 prior sons had died during circumcision from bleeding, that the third son did not have to be circumcised. And that is a link to hemophilia, which is an X-linked condition. So they had recognized this pattern in their community and recognized that they didn't know what it was, but that they could do something different to change that. So the concepts around genetics have been around for a long time, but it's taken us quite some time to actually get to the point where we could diagnose these things and actually do the testing. So I marked a few of those hallmark moments there, Darwin being a big one, talking about natural selection, Gregor Mendel in 1866 with his famous pea plants in Austria, talking about different inheritance patterns. And then this one was interesting too, that Broca, which some people know as a specific part of the brain that's named after Broca, described in his wife breast cancer in 5 generations of her family. So was actually describing much of what we know today about hereditary breast cancer. And that was back in 1866. The chromosome was first identified in 1902, which I think is pretty cool, and was sort of listed as the hallmark mode of inheritance. And then DNA was initially the structure defined in 1953 by Watson, Crick, and Franklin. Doctors Lee and Framini described a cancer condition within a family with sarcomas and breast cancer in 1969. And then it took till 1990 to actually identify the gene that was associated with what is now known as Lee-Framini syndrome. From there, I marked some of the big cancer genes and when they were identified. These were actually some of the first genes we were able to identify in genetics. Very few other genes were identified in the 90s. But then BRCA1 and 2 identified in 1994 and 95. And it took a couple of years to actually start testing for these consistently, but really blew open when we went to being able to sequence the whole genome. And the first case was that, I can't even see, 2003 up there. Yeah. 2003, thanks. And then it was only in 2011 when we started to do lots of genes at one time on a clinical basis. And so that was when we really started to sequence more. There was a big case in, what was that? 2013, where the BRCA1 and 2 genes were actually patented, and it was only one laboratory that was allowed to do sequencing of those genes. And it actually rose to the level of the Supreme Court, where the Supreme Court actually made a ruling that no, in fact, you can't patent the sequence of genes that are existing in all of humans. And that again blew things open and opened up the playing field for many laboratories to start offering genetic testing. So that was actually a big win in increasing accessibility for BRCA1 and 2 testing, and then really started to grow from there. So bringing us to where we are now, which is something we don't do much in cancer space, but it wouldn't surprise me if we move that way, and many people are, is to doing things like exome sequencing and genome sequencing, where we actually look at all 20,000 genes in the genetic code at one time and look for changes there. So this is the space where people are starting to look for new genes that have not been associated with cancers in the past, and trying to understand the piece that Amanda sort of mentioned about these perhaps familial cases that we're not understanding yet. So we still have a long way to go, but we've certainly come a long way as well. When we talk about the different types of testing that we can do, initially when we started and we just knew BRCA1 and 2 were related to breast cancer, that's where we started. And so testing was traditionally a single gene or 1 or 2 genes. And in some places, it was a mutation-specific test. So if you had Ashkenazi Jewish descent, you had the Ashkenazi Jewish variants tested, and they looked just at specific genetic changes in those genes related to your ancestry. And sometimes at the top of the pyramid here, we do targeted testing. So this is actually an important way for us to test families. If we know that someone in the family has a specific letter change, we don't have to look at all the genes. We just look at that specific letter change. So it allows us to be more targeted when we're looking at the family unit. But in general, the way things go now is we do these much larger gene panels. Usually between 50 and 200 different genes are on these panels, and we look more broadly because we found that we can't predict, and we're surprised every day. And Amanda and I, whenever we send testing, families always ask us, what do you think you're going to find? And we try our best to tell them that we don't know, because we're always wrong. So don't buy any lottery tickets. we never get it right. And that is a credit to how much we don't know about genetics and how much we don't understand about the human body and how much we have to learn. So it's really humbling to be in this profession and be able to be challenged with this information every day. But we do try our best to at least put things in general categories and do testing that makes sense for that person. So these are examples of sort of some of the genes here in pink that have been associated with breast cancer. So there's lots of them. But then on the other one with all the different colors, you can see that there's one gene, TP53, which causes Li-Fraumeni syndrome, that is associated with breast cancer, along with a lot of other cancers. So it's not always that one specific gene is associated with one type of cancer, and there are lots of different genes associated with each cancer type. Hence our panel testing. So why does this matter, right? So why do we care? What does this mean for us? And what it means is that the risk for somebody changes dramatically based on their genetics. And this is an example of what you can see in the general population, which is the general population risk for things like breast, ovarian, prostate, pancreatic cancer. And those are the tiny lines on the bottom. And then you see the familial risks and then the hereditary risks. There's a huge increased risk for some individuals related to their genetics. And this is an example of the risks related to BRCA1 and 2. So you can imagine that we would treat somebody and their family members differently who has a genetic change that puts them at a much higher risk category than somebody else. And this is another example of sort of the similar concept that breast cancer risk is different by each gene. And this is actually really important as well. It's not a one size fits all, and not everyone has the same risk. And this is actually a number that's been changing a lot. And some of the part of the talk today, we'll talk about a little bit of why. But these are sort of best estimates at this point at risks related to different genes. So you can imagine that your level of concern and their surveillance protocols may differ based on the different risk stratifications based on your genetic change. So one of the other things that identifying the genetic reason for someone's cancer risk is important is because it does change how we take care of that individual and their family. And the National Comprehensive Cancer Network guidelines, or NCCN, is an organization that there in blue is what they listed on their website as being their founding in 1995. And this is a network of cancer providers who issue annual statements about the guidelines to care related to different types of cancer. And they have a specific guideline related to genetic and familial high risk breast, ovarian, and pancreatic cancer. This is a clip from that guideline. It talks about the specific risks related to the different cancer types, and then links out to the information about how we actually take care of individuals who fall into those risk categories. And so this is something that is really a very active live document that changes over time. So what you may have been told at the time when you were diagnosed with an increased cancer risk related to a hereditary condition may not be the same 5 years later. And some of this has to do with our ability to identify cancers earlier and what types of screenings make sense in our health system at the time. But being able to put somebody into one of these categories and make sure we're following the NCCN guidelines is really significant in improving the care. Okay, so now we're going to switch to the last section here. So what's new? What's new in cancer predisposition? Where are we going from here? And one of the big challenges that we have is sort of redefining risk. What is the risk? And I think hopefully I've talked through a little bit about how that risk is variable based on each individual's germline genetic changes. But we also know there are other things that go into someone's risk. And Amanda has talked about some of these, family history, your exposures. And it turns out other genetic factors also play a role in all of this. And so those extra things that someone has that make us all a little bit different and our different exposures may not add up to much when you just take a couple of them. But it certainly can add up to something significant if your jar gets full of all of those combining factors coming together and increasing your risk beyond what we think of as a standard risk. So people have started to work on understanding how do we better decide who's got the half full jar and whose jar is overflowing? How do we make sure that we're taking care of each of those individuals? One of the long-standing tools we've used is a risk calculator. There are several of them, but the Gale and the Tyler Cusick are the most common. And this is a calculator that's been around for quite some time and takes into account lots of the woman's past medical history, her personal history. These are some examples, as well as the family history and ancestry. And then actually you can go and do these online. You can put in all this information and it tells you how much your risk is adjusted based on this information compared to the general population. So this is helpful, and that can be helpful in identifying those that may be at higher risk. But the newest kid on the block is trying to understand something else that can be help mitigate our risk. And that's the polygenic risk score, or PRS. And polygenic stands for poly, meaning multiple, genic, meaning genes. And that's exactly what this is. So the idea here is that if we look not at single mutations in our genetic code, like Amanda has described, but instead look across all the genetic code and are able to recognize certain areas where there are these changes, and those changes together have an impact on somebody's risk for cancer, that can be really valuable. And these specific changes are called SNPs, or single nucleotide polymorphisms. And what SNPs are? SNPs are actually normal. So these are normal variations between each of us, and they are different often based on our ancestry, as well as our lineage, and some are random and spontaneous as well. When we sequence enough people, that's when we can start to get a pattern that can emerge that certain SNPs together are impacting our cancer risk. And this idea of developing these polygenic risk scores started with big cohorts of data, big genetic data sets that were mostly involving European women. So this is something where we've started with European women and now have started to expand to try and understand broader populations. And so this is an example of how we can look at the polygenic risk score, or look at our SNPs. In this case, in the green, we're looking at 90 plus different sites or SNPs along the genetic code. And if somebody has a specific pattern in those SNPs, it could increase or decrease someone's associated risk related to it. So we actually can find that someone who maybe has BRCA1, who we think their risk may be the standard risk, but maybe they have protective SNPs that make it so that their risk is actually much lower, or perhaps they don't have those protective SNPs and their risk is much higher. So it works in both directions in adjusting the risks for those individuals. So one of the tools that has just sort of started in clinical practice is one of the commercial labs called Myriad, has started to roll this out actually on their testing. So in their genetic testing, as part of the result, they will actually look at the SNPs as well, and in some specific situations, report out a polygenic risk score. And it's been very interesting to see how that's changed the conversation with some of our patients who've had this testing. So it's not quite ready for prime time for everybody, but it's certainly exciting and interesting to think that we may be able to be much more accurate in our risk assessments for individuals and for their families. And many of the people this actually helps the most are the people who don't have cancer. So these are children who do not have cancer but carry an increased risk. Those individuals would be people that would be really important to do this type of testing on, as opposed to the person who already has cancer. So it's really powerful and changing how we think about the family and take care of the whole family. Okay, so just in conclusion, I hope we've sort of walked you through a little bit today of our understanding of hereditary cancer genes and genetics, that it's grown significantly, but we still have a long way to go and we have a lot that we don't know. We, again, only about 10 to 15% of cancers are hereditary based on our current knowledge and technology, but we suspect that there are much more that we're not yet recognizing. And then understanding each individual's breast cancer risk is really important to the care of that individual as well as the whole family. So we've talked today a lot about some of those risks and how it changes for each person. And it's really important that accurate risk assessments are done by allowing people to have access to genetic testing and counseling, and really doing that as part of how we take care of people who have breast cancer as well as their families. So from there, I would say thank you. And this is our information in our clinic here.
I am Dr. Thong. I'm a gynecologist with Bishop's Peak Women's Health, where our office is right next door to French Hospital if you need a gynecologist. So we're going to change gears a little bit and talk about menopause and breast cancer. So we're going to just briefly review menopause physiology. This is probably some high school biology as well, symptomatology, and then treatment, what we can do to help you feel better. So menopause is diagnosed retrospectively when you've had your last period, which you may not know at the time will be your last period, and then don't bleed again for 12 months. Then we say officially you're in menopause at that time. It results as a result of all your follicles. So all your eggs that you're ever born with live in follicles. And when over your lifetime, they are depleted and your estrogen levels start to fall, and your follicles are essentially gone, then we enter menopause. But before you get to that final period, women enter what we call the menopausal transition. So many years before, roughly about 4 to 6, but it can actually vary. It can be even as long as 10 or 12 years before your final period, you start to notice these symptoms. And I'm sure many of you have felt them, and it's really, really common. And I've listed them here. Probably the most predominant would be those hot flashes and night sweats, and they can be really, really bothersome. And up to 80% of women experience hot flashes and night sweats, and they can last up to 7 or 9 years. And actually, there's some reports that some women experience them for even upwards of 15, 20 years. So they can be really, really problematic and affect quality of life significantly. So this is kind of the gold standard of how we think about the menopausal transition. This was based on a study of, I think, roughly 3,000 women that they started to follow for 15 years, beginning around the age of 45. And so we have the final, I don't think I have a little light, but
it's on the top, very top button, just the red light.
maybe. Oh, yeah. So the final menstrual period here, but you can see all of this time here is when you start to have those symptoms described. And then even after your final period, for many years thereafter, you can experience those symptoms. This is showing you just like the hormones. So the FSH and LH are hormones released by your brain. Those are the hormones released by your brain and talk to your ovary. And then the ovary is where you release estradiol and inhibin. And so it just kind of tells you, so this is a woman who in the menopausal transition, the dashed lines here represent when she's bleeding, and you can see how erratic it is. Like she went 99 days and then had a period, and then 31 days and had a period, and then 27 days. And so it's just really erratic. And then you can see what's happening with her estradiol. So this brown represents her estrogen levels. So at any given point, you can have testing, and it might be really high if you happen to draw your blood here, and then you draw your blood here and it's really low. So when women come to my office and they say, I don't feel well, I think you need to check my hormones, my answer usually is, we don't need to do that, because I don't know if we're here or here. And at the end of the day, it doesn't matter, because it's more important like how you're feeling. And if you're feeling poorly, we're going to address your symptoms, and it doesn't matter what your hormone level is actually going to be physiologic. It's going to be appropriate for your age and where you are. But there is so much variation in any given day, week, month, year over the course of the menopausal transition. So this is the graph of just showing you what hot flashes can be like for women. Yeah, it tells the story. So for the 0 represents the final menstrual period. So all these years before you get there and all these years after, this is what hot flashes can be like. So hormone therapy does remain the most effective treatment. But I know for most of you, if you've had breast cancer, it's not an option. So very briefly, this is probably nothing new. You guys all know this, that it is the second leading cause of death, and the number one risk factor is age. So breast cancer is challenging because you may not be in menopause, but sometimes the therapies that we use in breast cancer will put you into menopause. And if not, again, age being a risk factor, a lot of women are entering menopause when they get diagnosed with breast cancer. So it's a common concern. So now we're going to talk about non-hormonal therapies to help. And I just want you to be aware that I got all of the non-hormonal therapies that we'll be discussing is through the North American Menopause Society, which is kind of the leading authority on all things menopause. And so I encourage you to look at their website for more information. So women who have a history of breast cancer, women who have some of these other risk factors are encouraged to avoid estrogen. And so this is who the non-hormonal therapies will be valuable for. So as far as lifestyle, you've probably heard a lot of people, including your physician, tell you like, oh, dress in layers, have a fan nearby, things like that. So according to the NAMS, North American Menopause Society, they say, reviewing the literature, the burden of evidence suggests that it's not been shown to be helpful. So if you take women who do these things and you ask them, are you better? No, it's not better. The one lifestyle measure that was helpful was weight loss. So if women lost weight, they did find that they had less frequent hot flashes. Mind-body technique. So cognitive behavioral therapy and clinical hypnosis were both things that seem to help decrease the number of hot flashes. These 3 things did not. So prescription. So traditionally, these things were prescribed, but they're finding the data is suggesting that no, it's not helpful, or it is, but the side effects are so bad and we have better things. So they're saying maybe don't use these things. And then these are things that are much more helpful. So traditionally, like antidepressants, gabapentin, which is often used for like chronic pain, and then oxybutynin, which is most commonly prescribed for overactive bladder. So, you know, the commercial, gotta go. So it works really great for that. It prevents less bladder spasm, but it also has been shown to decrease the number and frequency of hot flashes, which is kind of nice. And then this is the new amazing medication for women who cannot be on estrogen. This was just approved by the FDA in May. And the technology is that it's affecting the cause of hot flashes in the brain. So really cool. It's called Veozah or fezolinetant. And so there are these specific neurons near our hypothalamus, which is where our temperature control happens. And they have identified that this neurotransmitter called neurokinin B is overstimulated and will cause you to feel hot. And this medication is a blocker. It's an antagonist, so it blocks this neurokinin B. And the articles I read, the trials that they did, it was very effective with very few adverse effects. Like headache was maybe one of them, but that was like the most common. And it was like out of hundreds of women, only like 6 women complained of headache, you know, or like 1 woman complained of like stomach upset and things like that. So the adverse effects, the profile was very good and the effectiveness was very good. I think it decreased hot flashes by like more than 50%. But because it's new, by the way, if we prescribe it, it's probably going to require prior authorization and we're going to have to like with insurances and all of that. All of these supplements, according to NAMS, there's not an overwhelming burden of evidence that it is helpful. So I get a lot of these questions too, like, can I take this stuff over the counter? I would never say no, because it's probably also not harmful. And I have had patients tell me, oh, I took black cohosh and it's helping me. And I would say, if it's helping you, keep taking it. But if somebody asked me, I'm not taking anything, should I take black cohosh? My answer is going to be the evidence says, no, it is not better than placebo. And then this is actually a therapy, doing my research that I came across. I was not even aware of this. So it is this procedure. Apparently you can inject an anesthetic into a bundle of nerves right here in front of your neck. And it's apparently very effective, but I don't know who's up for an injection in the neck. So there's that. Okay, so GSM, this is also part of what happens with menopause. So specifically your genitalia becomes very dry and thin and irritated, and it's hard to have sex. It's very uncomfortable. What we have found is that, again, low-dose vaginal estrogen, topical vaginal estrogen in the vagina is like most effective. And the studies do not seem to increase risk for breast cancer recurrence. So I know that a lot of oncologists will say, what, estrogen? No way, no way. But if you look at the data, it seems to suggest that it's safe. So if it's a quality of life issue, I have had patients who do it, but I've also had breast cancer patients who were like, I'm not comfortable with that, and that's fine. So then you can try things like moisturizers and lubricants. So that's a conversation we could have for sure. I get a lot of questions about bioidentical hormones. So the word bioidentical, it literally means like identical to what your own body makes. So our ovaries make E2 estradiol, but yet in like the commercial market, they've like taken this word and made it sound like it's something that only our clinic does. So you come here and we'll measure your hormone levels and then we'll give you exactly what you need. And that's unfortunate because that's just not true. Oops, sorry. So it's basically like they'll measure it and then they give you a prescription and then you take it to a compounding pharmacy. But the problem is it's not regulated at all. So from one compounding pharmacy to another, you don't know what you're getting and you don't know how much you're getting. So it's actually kind of dangerous and I really don't recommend it, and probably really expensive. So in summary, menopause can be really challenging and it's very uncomfortable and affects quality of life, and we don't need you to be uncomfortable. So go talk to your doctor, and we can find something that's gonna work for you. And I think that's it.